Okay, good evening, students. Today's topic that we're going to deal is AIDS and periodontium, or we can see pathology and management of periodontal problems in patients with HIV infection. Okay, let's just give you one small idea. We already know AIDS. Everybody has learned. Even in your third year, you have a record where you've written down about HIV syndromes and HIV periodontal manifestations. We know the clinical stagings of clinical stages of HIV infection. We know which are the chemotherapeutic agents that we use. So I'm just going to give you a small, very in a bubble, short bubble idea about, just so that you can memorize. AIDS. So what is AIDS? Acquired immunodeficiency syndrome. And it is characterized by profound impairment of immune system, meaning there is a impaired immune system caused by infection with immunodeficiency virus. And such patients with HIV, they usually have a lot of severe infections, including opportunistic infections and tumors that usually does not affect people, with a working immune system, or if there is no impairment in the immune system, these infections and opportunistic infections don't usually affect them. But in HIV cases or HIV patients, there are a lot of infections, including opportunistic infections, because of their impaired immune system. Now, which is a viral pathogen which is involved in AIDS? It is the human immunodeficiency virus, or HIV virus. And this was identified in 1984 by Montenegro et al. In France. And what is the pathogenesis here? This virus, or the human immunodeficiency virus, they have a strong affinity for cells of the immune system, the immune cells, which are your CD4 cells, absolute CD4 cells, your T lymphocytes, your monocytes, macrophages, Langerhans cells, and some neuronal cells. And what do they do when they have the affinity? They'll go and impair, or they will change their action, and this will lead to the release of pro-inflammatory cytokines. We know which are the pro-inflammatory cytokines, right? We can give you TNF-alpha, tumor necrosis factor, okay? Alpha, then we have interleukin-1 beta, we have interleukin-6. So these are all the pro-inflammatory cytokines. So they are released when the viral pathogen, they go and affect the immune system cells, which are the CD4 cells and the absolute CD4 cells and the T lymphocytes, the monocytes, the macrophages, Langerhans cells, and the neuronal cells. And they will release these pro-inflammatory cytokines and other mediators. Now, this is just the anatomy of the AIDS virus. I've just put it in so that you can get a small picture of how it looks. Now, where does a viral replication occur? The viral replication occurs continuously in the lymphoreticular tissues of the lymph node, the spleen, gut-associated lymphoid cells, and macrophages. And here, like I already mentioned, which are the cells? The CD4 cells and the T lymphocytes. So usually we say the B lymphocytes are not infected, but what we see is that the altered function of infected T lymphocytes secondarily can result in B cell dysregulation and altered neutrophil function. So ideally it does not affect, but after the altered function of T4 lymphocytes, as a secondary action, it can cause B lymphocyte dysregulation and altered neutrophil function. Now, in HIV cases or AIDS patients, there is increased risk for malignancy, increased risk for disseminated infections. There is increased risk for adverse drug reactions, ADR, due to altered antigenic regulation. And this HIV virus is mostly detected in high quantities only in the blood, semen, and the cerebrospinal fluid, or the CSF. And we already know, it's common knowledge. How does the transmission occur? It occurs through sexual contact, illicit injection, use of injection drugs, or exposure to blood or blood products of HIV patients. Now, when we start treating these HIV patients, what are our goals? It is to reduce the HIV-related morbidity and mortality, okay? we have to, since we have already discussed that it is affecting the immune system, so we need to restore and preserve the immunological function. We also need to suppress the viral load, which is your HIV virus. So we need to suppress the viral load maximally and durably. So these are the three goals of treatment. We need to reduce the HIV-related morbidity and mortality. We need to suppress the viral load, and we need to restore or somehow preserve the immunologic function. Now let's go to the classification. According to Center for Disease Control, or the CDC surveillance case classification, AIDS patients have been grouped as follows. We have category 1, 2, 3, or category A, B, and C, you can name it. Category A, which are the mild, those patients who have just stage 1, maybe stage 1 HIV. These are patients which have acute symptoms or asymptomatic diseases, along with individuals with persistent generalized lymphadenopathy. They may or may not have malaise, fatigue, or low-grade fever. So they're all stage 1 cases. And how do we see them? It is, they have the immune system, immune cells, they have more than or equal to 500 CD4 lymphocytes per millimeter cube. And that amount is very important, that ratio. So category A, or the mild or stage 1 HIV cases or HIV patients, have more than or equal to 500 CD4 lymphocytes per millimeter cube. Now coming to category B, these are patients who have symptomatic conditions, like other one didn't have any symptoms or they were asymptomatic, category A. But in case of category B, they have symptomatic conditions such as oropharyngeal, vulvovaginal candidiasis, herpes zoster, oral hairy leukoplakia, idiopathic thrombocytopenia, constitutional symptoms like fever, diarrhea, and weight loss. And what is the ratio of lymphocytes here? 200 to 499 CD4 lymphocytes per millimeter cube. Okay. Now we come to the category C, which is the full-blown HIV patients. So these are the patients with full-blown, life-threatening. They also have bacterial, viral, and protozoal infections. And they are also identified with the count, that is CD4 cells and lymphocyte cells of less than 200 cells per millimeter cube. So category A, mild or stage 1, they have more than or equal to 500 CD4 lymphocytes per millimeter cube. Category B, they are symptomatic and they have a count of 200 to 499 CD4 lymphocytes per millimeter cube. And category C, which are full-blown HIV cases, they have less than 200 CD4 lymphocytes per millimeter cube. So this is the CDC surveillance case classification. This was given in 1993. Now, how do we treat? Now, there are certain chemotherapeutic agents which are used in the treatment of HIV. So this is called the HAART, H-A-A-R-T, or highly active antiretroviral therapy. And there are a few drugs which are there in this. There are 4 types of drugs. We have the nucleoside reverse transcriptase inhibitors, NRTI. Examples are lamivudine and stavudine. Non-nucleoside reverse transcriptase inhibitors, or NNRTI, dalavirdine and nevirapine. Protease inhibitors like indinavir and ritonavir, and entry or fusion inhibitors. Now, these drugs, when they're used in a combination, okay, they can be used in a combination, and I'm sure you've written this. This was there in your 3rd year record writing, right, when you were writing about HIV. And these drugs, when used in a combination, they will reduce the viral load. They will increase the absolute CD4 plus lymphocyte count. That is what we need for treatment. Okay. So HART, highly active antiretroviral therapy. And these are the 4 drugs which are used. And the combination of these can reduce viral load, increase the immune cells, absolute CD4 plus lymphocyte count. Now coming to, that was the general idea about HIV and HIV virus and AIDS patients. And now we come to, what are the periodontal manifestations of such patients? What are the periodontal lesions which usually come for HIV infected patients? Now, before in 1993, there was a classification. This HIV associated periodontal lesions were classified as HIV associated gingivitis, HIV associated periodontitis, necrotizing ulcerative gingivitis, and stomatitis. But later on, they realized actually that this term HIV was taken off. Why? Because when they use HIV-associated gingivitis, but gingivitis as such can be present in normal periodontal patients without HIV as well, meaning HIV negative patients can also have these periodontal lesions, right? So that is why they removed the HIV term. It was not HIV associated gingivitis anymore. So later on, in the same year 1993, I think it was by EC Clearinghouse, they accepted the classification as the HIV-associated periodontal lesions, including linear gingival erythema, necrotizing ulcerative gingivitis, necrotizing ulcerative periodontitis, and necrotizing ulcerative stomatitis. So the HIV term was removed, okay, because these lesions are also can be present in HIV negative patients as well. Now, what is the pathogenesis? I've already given you a small summary. What are the risk factors for periodontitis in HIV positive patients? The risk factors are age, smoking, the viral load, the amount of viral load, microorganisms, okay? And when we see that is a category C or the category 3, what did we see? They had the cell count of less than 200, right? So the patients with advanced stages of HIV, a full-blown HIV infection, what happens? They have a decreased absolute count, that is of less than 200 CD4 lymphocytes per millimeter cube in the blood. So this will lead to a complete depression of the immunity or immunosuppression. And that is a risk factor for gingival inflammation. We already know that periodontal disease is it's a combination of many things, right? It is a multifactorial disease. So that means this is a risk factor for gingival inflammation. When the immunity is suppressed, obviously there is a chance for inflammation. So what did we say the pathogenesis? Patients with advanced stages of HIV infection, they have less than 200 CD4 lymphocytes count per millimeter cube count in blood, which will lead to immunosuppression, or all these immune cells are affected. We have already told that in the pathogenesis, and it is a risk factor for gingival inflammation. And we should also know that periodontitis will progress more rapidly in HIV positive rather than HIV negative patients because immunity is hampered. Both local and systemic post-inflammatory and humoral immune response will play a role in progression of periodontal disease. And here the lesions will show high plasma cells, mast cells, macrophages, and neutrophil release. There is an increased plasma cell, mast cell, macrophage, and neutrophil release of pro-inflammatory cytokines. These cells will start releasing all the pro-inflammatory cytokines and other mediators when this happens. Now, coming into detail, we have already said about the periodontal lesions, HIV-associated lesions. So let's see what are their general clinical features and what is the treatment. First one we mentioned was linear gingival erythema. Now here they have gingival manifestation of immunocompromised patients. So this is what the first manifestation that we see, the gum manifestation of immunocompromised patients is linear gingival erythema. They have a distinct linear erythema limited to the free gingival margin. Don't worry, I've added some pictures also. Okay, so this is a gingival manifestation of immunocompromised patients. They have a distinct linear, there is a distinct linear erythema which is limited to the free gingival margin. And for such cases, conventional periodontal therapy, that is plaque control, scaling, root planing, has no response, okay? So the lack of response of linear gingival erythema to conventional periodontal therapy, which includes plaque control, scaling, and root planing, this is the key diagnostic feature for linear gingival erythema. They do not respond to any conventional therapy. And this is most commonly associated with the anterior teeth. Another key feature is that these lesions usually are accompanied with concomitant oral candidiasis as well. You can find some candida albicans, candida lesions there. and LGE lesions, they have been identified, suggesting a possible etiological role for Candida species. So most of these cases will also have candidiasis. And you can say linear gingival erythema is a potential clinical marker of HIV infection. You can stamp on it. Okay, so it is a potential clinical marker of HIV infection. As you can see by my cursor, you can see the distinctive erythema. See, erythema is a line. It's a reddish line along the free gingival margin, and it is mostly in the anterior teeth. Okay, and along with this, you can even find some Candida albicans sometimes. Now, how do we treat them? Meticulous oral hygiene is definitely necessary. Scaling, subgingival irrigation with chlorhexidine digluconate, that is 0.12% of chlorhexidine digluconate, can be used as mouthwash. And if it persists, you have to evaluate, and candidial infection should be evaluated and retreated if necessary. That is with corticosteroids. Coming to the second one, which is necrotizing ulcerative gingivitis, or ANUC. This is characterized by ulcerations, as the term, as the heading, or as the name suggests, ulcerated necrotic papillae. The gingival margins are covered by pseudomembrane, which can be rubbed off. When you use a gauze on it, you can see it's sloughing off. And it is associated with intense pain. There is spontaneous gingival bleeding, may or may not be associated with depressed CD4 T cell count. So this is not exactly a potential marker. Okay, so you cannot call necrotizing ulcerative gingivitis as a marker for HIV infection. This can be, that is what I said, it can be present in just periodontal conditions. It may or may not be HIV positive, or it could be even negative patients may have necrotizing ulcerative gingivitis. So it is not associated with depressed cell count. You can see here, necrotic papillae, you can see it's ulcerated, necrotic, spontaneous bleeding. If you put a probe, you don't even have to walk the probe, you just need to touch. Give a slight movement and it'll bleed spontaneously. And that sloughing off, you can see if you use a gauze over that necrotic papillae, it will slough off, pseudomembrane. How do we manage them? Debridement of the necrotic lesion. It has to be scaled and root planed. Chlorhexidine, 0.12% chlorhexidine digluconate mouthwash with meticulous oral hygiene has to be followed. Antibiotic treatment, metronidazole 400 mg twice daily for 5 to 7 days. Now, necrotizing ulcerative periodontitis. Now, how are they characterized? Gingivitis can accelerate to periodontitis. This is characterized by ulcerated gingival papillae. There is rapid bone loss. So it's not like gingivitis. It has a rapid loss of bone and soft tissue associated with severe pain, fetid odor, loosening of teeth. There is spontaneous gingival bleeding accompanied by lymphadenopathy, fever, and malaise. This is the marker for severe immune suppression. So like how, which was mentioned, gingivitis is not a marker for CD4 depleted cells, CD4 depletion. Here, this is a marker for severe immune suppression. There is also increased occurrence of candidiasis. This can be called as a predictive marker for this cell count, CD4 lymphocyte count of less than 200. So this is mostly seen, definitely seen in category 3 patients or C patients. And then you can see here, debridement of necrotic soft tissue utilizing 0.12% CHX, digluconate or chlorhexidine digluconate or povidone iodine lavage. You can even use iodine, povidone iodine. Scaling and root planing and subgingival irrigation. Antibiotic, which is metronidazole 400 mg twice daily for a week. Prophylactic systemic antifungal agent has to be given if there is usually accompanied because of candidiasis, and there should be frequent follow-up visits. Now, when this is progressing, it leads to necrotizing ulcerative stomatitis. Severely destructive, acutely painful, and it will affect significant areas of the oral soft tissue and underlying bone. And it occurs separately, or it could be an extension of necrotizing ulcerative periodontitis. Okay, so it can occur separately as an entity, or it is also an extension of necrotizing ulcerative periodontitis, and it is usually and it is associated with severe suppression of CD4 immune cells. Condition will appear similar to cancrum oris, which is NOMA, which is a rare destructive process reported in nutritionally deprived individuals, and it is caused by a fusobacterium. Okay, so this is very similar to cancrum oris or NOMA, okay, which is usually present in nutritionally deprived individuals. Management, again, debridement of necrotic soft tissue utilizing 0.12%. Chlorhexidine digluconate, scaling and root planing subgingival elevation. Full conventional periodontal therapy has to be followed. Antibiotic, metronidazole 400 mg, twice daily for a week. If the osseous necrosis, bone loss is present, remove the affected bone to promote the wound healing. So that is what the periodontal manifestations of HIV infected patients. Now there are some general cardinal lesions which are affected with HIV infection, and those 5 to 6 oral cardinal lesions which have to be mentioned also, which can be which may or may not present as a periodontal lesion. This is definitely there in HIV patients. So these are there are 6 to 7 oral cardinal lesions which are associated with HIV infection. First, oral candidiasis. Now, we already mentioned about all those in and against stomatitis. This is caused by Candida albicans, most common oral lesion. 90% of HIV patients will have candidiasis. And how do they present? There are 4 types of candidiasis. We have pseudomembranous candidiasis, erythematous candidiasis, hypoplastic, angular cheilitis. Treatment is with topical and systemic or systemic corticosteroids. Oral hairy leukoplakia, again, primarily occurs only in HIV infection. They are found on the lateral borders of the tongue. They're also seen in the dorsum of the tongue, buccal mucosa, floor of the mouth, retromolar, and soft palate. And they're caused by human papillomavirus and Epstein-Barr virus. Again, treatment by antiviral agents such as acyclovir or valacyclovir. Lesions can be successfully removed either using a laser or conventional surgery. Kaposi sarcoma. This is again an HIV positive individual with Kaposi sarcoma can be categorized as having AIDS. Again, it is a predictive marker. Okay. Most common oral malignancy, which is I already told you there are a lot of infections and malignant tumors which come with HIV patients. So this is one of that distinctive malignancy which is there in HIV patients, Kaposi sarcoma. And most common, this is also the most common oral malignancy which is associated with HIV patients, angiomatous tumor, which is a rare multifocal vascular neoplasm. It's caused by HHV8, human herpes virus V8. Okay. Malignant tumor which is localized. This is a malignant tumor. Kaposi sarcoma is a malignant tumor which is localized and slowly growing lesion. And again, we use for treatment, we use the HART, what I already mentioned that, right? HART, those are the combination of those drugs. Then we have antiretroviral agents, and it could be also done by laser excision. Bacillary or epithelioid angiomatosis. Again, it is an infectious vascular proliferative disease caused by rickettsia-like organisms. Diagnosis can be based on biopsy, and the biopsy reveals an epithelioid proliferation of angiogenic cells, which is accompanied by an acute inflammatory cell infiltrate. Treatment, broad spectrum antibiotics, erythromycin, doxycycline, and the gingival lesions can be managed using antibiotic with conservative periodontal therapy and excision of the lesion. Oral hyperpigmentation. They appear as spots or striations on the buccal mucosa, palate, gingiva, or tongue. Pigmentation may relate to prolonged use of drugs such as zidovudine, ketoconazole, or clofazimine. Zidovudine, which is associated with excessive pigmentation, even when you use a lot of zidovudine, you can also see excessive pigmentation of skin and nails, black pigmentation of the skin and nails. atypical ulcers, which will be the last cardinal lesion, recurrent herpetic lesions, and aphthous stomatitis. This is association with enterobacterial organisms such as Klebsiella pneumoniae, Enterobacter chloroicae, and E. coli. Herpes simplex virus, varicella zoster virus, Epstein-Barr virus, and cytomegalovirus. They are frequently retrieved from the microbiology of non-specific oral ulcers. So that's it. This was to the topic. Actually, I have presented in such a way that this is all you need to know. And if a question comes on HIV, this is what you have to write. Okay, so I'll just give a brief of what we have already said. First, we talked a little about the AIDS. We need to know the classification, how the CDC has classified AIDS patients as category A, B, and C. You need to know the cell count. What are the agents which are used, general agents which are used in treatment of HIV, HART, combination of 4 drugs. What are the periodontal manifestations of HIV infection? We have linear gingival erythema, necrotizing ulcerative gingivitis, necrotizing ulcerative periodontitis, and necrotizing ulcerative stomatitis. You need to know their presentations, clinical features, and their management, and what is the pathology which is involved in this. Okay, and then finally we talked about the 6 cardinal lesions which are associated with HIV infection. So I hope you've understood, and on coming Friday we'll have a discussion on this. So you can jot down these points in a paper or in your book, okay? And I can ask you a few questions. If you have any doubts, please ask me on Friday. Okay, so we'll see you on Friday. Thank you.